My name is Doung. I'm from the, let me try to move this down since I'm very short. I'm from the University of South Florida. I'm currently a PhD student. This is technically my first year at University of South Florida, but I'm a transfer student. So technically third year. So I'm doing my qualifying exams hopefully this fall. My research was looking at screening practices for colorectal cancer in Vietnam. So Vietnam, located on this map, capital city Hanoi, has a population of about 93 million, which counts as the 14th most populous county on Earth, and has 48 provinces. In terms of the incidence or prevalence of cancer, colorectal cancer in particular worldwide, 14 million new cases, and it ranks as the third most common cause of cancer death. In particular, looking at Vietnam in comparison, it's a lower middle income country and accounts for 12.7 per 100,000 population that gets colorectal cancer, and ranks as the fifth most common cancer among both genders. In terms of screening for colorectal cancer in the general population, we know that it's important in terms of prevention and control in order to identify pre-symptomatic individuals so that they can be identified for treatment, because the earlier you catch it, the more likely the treatment will be able to prevent or cure the disease. And cancer prevention should focus on modifiable risk factors because a third of the deaths are accounted due to behavioral and dietary risk factors. In terms of the annual new cases of colorectal cancer in Vietnam, about 3 times increase from 2000 to 2013 occurred, according to Vietnam National Cancer Hospital. As a result, we definitely need to incorporate cancer screening so that we can prevent more cases in the future. In Vietnam, colorectal screening is at its infancy stage, and the current test that they use for screening is the fecal occult blood test, or FOBT, or the fecal immunological or immunochemical testing, FIT, bowel cancer screening via exam or colonoscopy. Currently, there's a paucity of research on the carcinogenesis and risk factors for this disease, and in general for cancer screening for colorectal cancer. And this is a natural history of colorectal cancer, or CRC. Generally, there's genetic mutations or mismatch in DNA repair on the DNA, which causes dysbiotic changes, induces early carcinoma to late adenoma, and then to carcinoma cancer. And this is the picture of the colon where colon polyps can develop or colon cancer. And so we're interested in the early adenoma stage to the end, which is the cancer, number of cancer cases. And risk factors for the polyps and colorectal cancer that are shared between them, you can see in red are the risk factors that increase the incidence rates of colorectal cancer, smoking, alcohol, etc. And in green are the protective factors, including vitamin D and fiber intake. In terms of colorectal cancer screening in general in Asia, you can see that by country there's variability in the age that you first start screening. In Japan, with the lowest starting at greater than or equal to 40, and then 61 in Hong Kong, but then the end is 75 for China and Taiwan, with no cutoff for the other ones. And also the diagnostic methods are colonoscopy. And FOBT is also the initial method that they use in most countries, all countries. In terms of the FOBT test followed by colonoscopy for confirmation, you can see that there are a few studies in Japan, Korea, and Singapore that looked at the FOBT positive and the number of abnormalities in terms of the colonoscopy advanced polyps to non-advanced polyps. And in general, you can see that in Korea, there was a 7.28% FOBT, and based on a preliminary study conducted, we assessed that our rate would be similar to the 7.28%. And you will see later that this is actually true. In terms of the gaps and challenges in colorectal cancer screening in Vietnam, identifying the high-risk population is of great importance in terms of screening because of modifiable risk factors related to the development of colorectal cancer and markers that are present in the adenoma development. CRC screening in particular in Vietnam is at its early stage, and it's because it's a lower middle income country, so they have limited financial resources, and they're also underdeveloped infrastructure for supporting this program. And also, the risk factors in terms of the genetic basis for CRC risk have not really been identified in the Vietnamese population. And so this is the first study to do so. In terms of the first phase of our study, we did a pilot screening questionnaire to assess what the effectiveness of the questionnaire in assessing the questions that we wanted to do. And so we evaluated the results of this pilot screening questionnaire and also took note of recommendations for improvement before we actually disseminated the questionnaire to the public. So the convenience sample of 34 subjects from related to either the family, friends, or neighbors of the team members. And screening practice questions that were asked included demographic, smoking, and dietary habits, as well as anthropometric information and physical activity, medication, and disease history. And then for women, the reproductive health factors. The results of the pilot screening showed that predominantly there was about 40% of the study participants were between 40 and 49, and the rest fell in the 50, 59, and 60%, greater than 60 age group. And in terms of gender, there were predominantly females that took the test. And in education, it was pretty evenly split, a third for secondary, high school, and college or above. And then occupation, it was the workers and the other, as well as the administrative staff that made the great proportion of this population, and the rest fell into the other categories. The thoughts on the length of the questionnaire, most people thought that it was moderate, followed by long and too long in terms of the length of the questionnaire. And the layout of the questionnaire, we asked if the readability, the letters are too small and difficult to follow the skip patterns. And you can see that there's variability in terms of how they answered that, and that it was generally pretty readable, about 53%. Letters were too small, 35% said that, and 28% said it was difficult to follow skip patterns. And then in terms of the general comments for the screening questionnaire, you can see that people said it was difficult to recall past exposure experiences or just past experiences in general, and that for some people, more instructions were required, and in particular for the elderly, they needed more instructions on how to fill and read the answer or questionnaire. And then for the content, you can see that some thought more instructions were needed in order to understand how to fill out the questionnaire, as well as definitions for diseases, and some felt the questionnaire was too long, as well as the quality of the survey could be improved in terms of shortening the questionnaire. We conducted educational campaigns in Times City, and it was well attended by the public. And this is Dr. Chi Tran, who is the co-PI in Vietnam on the study, who's talking about the survey. And then the survey is administered in Vietnamese, and she's going through the different survey components of it. And for this one, you can see that she's teaching them how to use the FOBT kit, and also there's a scan label that you need to affix to the FOBT once it's been taken the sample, and then put it back into the sealed envelope. And you can either mail it back with a questionnaire to the office, or they usually drop it off at the lab. And then we also conducted a clinical research methodology course for the health professionals there, because this is the first time that they're learning about public health and research methodology, and a lot of them are interested in doing studies related to treatment and care. And so this is their first exposure to it. And Dr. Bofetta is the one leading it, and I was the TA for the course. And so this is just a sample of the procedure for putting together a kit. We made about 10,000 of them, and there's still about 90,000 left to make. But it's quite a process, and we have boxes and boxes of these kits, and I'm just surrounded by them, so they're waiting to be disseminated to the public. The second phase is looking at the questionnaire going live, and we were looking in particular the screening rate among Vietnamese, calculating the prevalence of colorectal cancer in the population, and then comparing the screening practices prevalence with Vietnam compared to other Asian countries using a systematic literature review, and then determining predictions for screening practices in Hanoi, Vietnam. Oops, sorry. The overall view of the study is that we're going to collect over 100,000, and we are expecting about 6.7% FOBT positive, which is about 7,000, and of those, estimating about 42% polyps. And this is from the Singapore study, the 42 which is divided into 23 and 19%, and what they found, and we're thinking that we'll probably see the same thing. And then of those, 3% will be confirmed positive, 211 cases. And so the survey was based on, will be based on in-person interviews. So we have the self-administered component and then the interview-based, which will only be on a select number of patients for case and control, because we have limited resources to do all interviews on 100,000 population. And then there are screening practice questions that we will give as well to answer the questions. And the structured questionnaire will include information on personal habits, demographics, medical history, reproductive history, as well as family history and occupational history, and dietary habits. We do have a screening questionnaire about Agent Orange during the Vietnam War, but beyond that, we don't have exposure information to minimize the risk of confounding for that exposure. And FOBT and fecal information were collected. So currently the initial results for our screening is that we have collected about 10,000 surveys out of 100,000, and so that screening rate from January 2018 until now, about 7 months, is about 10% screened. And then the prevalence so far is 6.3 FOBT positive out of 10,000. And because it's still an ongoing study that needs to be conducted, we're not able to do the logistic regression I wanted to look at the exposure and outcome related to CRC screening. And also there's lots of missing data because it was self-administered survey. And so this is actually a breakdown of the 6.3%. And you can see that within the villages of the Hai Ba Trung community, that there are variability in the FOBT positive in red. And also, there are some people who got really interested in the study because they heard it from word of mouth. And even though they weren't set to be screened yet, we allowed them to be screened if they met the criteria of being the age range. And so that's why you see that there's like 2 people from one village and more representative of others. In terms of the colonoscopy cases, we have about 253. And of those, 152 were polyps. Unable to confirm were 4, and then tumor were 9. And then histology confirmed for polyps was 54%, and then the cancer was 9. And then total cancer was about 14 or 5.5% of the population. The systematic review is also another part of the study where I screened almost 2,500 articles, and of those, for full text review, about over 400. And we're going to look at the screening prevalence in Asian countries. And so far what I've seen in terms of patterns is that there's a range of screening prevalence ranging from 10 to 100%, and also variability in the types of screening modalities used, with FIT, FOBT, and colonoscopy being the most common. In terms of things to improve, it's a multi-pronged approach because there are lack of policies, and you need to establish cancer registration, increase functional support for surveillance, and educating community and training staff about referring patients for screening who meet the criteria, as well as improving access to care and removing barriers to care. And then, in conclusion, we would like to examine the screening practices and their impact on the detection and prognostic indicators for CRC and polyps in Vietnam. And we hope to inform the disease surveillance and policies to strengthen practices to reduce the burden in Vietnam. Proposed future analysis, including expanding the self-administered questionnaire as well as the interview questionnaire in the different districts, and also examining the predictors of screening practices in Hanoi, and determining barriers to screening also. Learning experiences were multifaceted in terms of learning about the screening tools as FOBT and colonoscopy, as well as analysis using SAS, and the challenges of data collection, because we thought that by this time we would collect more than 10,000, only 10% of the sample. But with research, we know that it's often a challenge, and because of limited staffing, we weren't able to get as much as we want. And I think now they're anticipating 18 more months to collect, hopefully more. And I get a better understanding of the disease surveillance in terms of the principles and practices and the cultural expectations and knowledge in the public, which are limited currently, and also about how to collaborate efficiently and effectively with domestic and international partners. In terms of future topics, I think educational awareness about screening in the public and identifying barriers at different levels, and also about maybe a systematic literature review on screening interventions and cost effectiveness of the program, as well as comparing screening modalities and differences. So the strengths were the strong expertise and research team, It was funded by the International Hospital, so there was support for the study and the data collection. Staffing was there, although limited, and biospecimen storage was available as well. Also, well-organized team, efficient and methodological, and everyone was very enthusiastic and supportive mindset. But there were language barriers, so these are limitations, and there's only one statistician, me, to help with analysis, although we did have a data manager. And data sharing was difficult. I still have been having issues with getting the actual data for the screening, and because we're still collecting it. And also, they don't want to publish anything yet until they got a handle on it. So my future career goals, I wanted to put this blurb up, but I'm hoping to do the qualifying exam in the fall, and then do my dissertation on Florida 1 data, which is looking at hepatitis C screening in the baby boomer population, and we're hoping to do GIS mapping of Florida to map out the differences in screening rates. And so completing my PhD by, I'm hoping, 2020, and then identifying mentors in cancer epidemiology and applying for jobs as a cancer epidemiologist, as well as continuing to grow as a researcher. And this is the mentorship team: Dr. Liu, Dr. Buffetta, Dr. Chi in Vietnam, and Dr. Kevin Kip. He's my major advisor at USF. And then this is a research team: Dr. Mai, who is the research coordinator. This is Dr. Buffetta and Dr. Liu, and this is Dr. Mo Tran. And then this is the IT person, who is actually the main person that enters all of the data. And this is Dr. Chi. And then this is the laboratory staff headed by Dr. Tui and Linh Fan, and then the Trang Trong is also here. And then we also have a research assistant, Nung Din. And I also wanted to thank the CEEP, especially Dr. Solomon, Dr. Chamberlain, and for the staff, Sam, Hannah, and Michelle, for all they do, and I appreciate all your help. Thank you. You have questions? Yes.
Thank you. I was just wondering if you could speak a little more to the difficulties of data, and can you get biospecimens out of Vietnam?
Yes, actually we were trying to figure that out with Dr. Buffetta, because he was going back and he needed to have samples sent. So we were juggling, I guess, the customs in Vietnam to see if he could store the biospecimens and take it through customs. And he was actually able to do it because he's not from here, but if he was from Vietnam, he would have more difficult time. Because he was a foreigner, it was a little bit more easier to get it. So we were successful.
So what's the issue with data then?
Data is missing for the survey questionnaire because it's self-administered for the majority of it. So people don't answer the questions, and there's lots of missing fields.
Oh, I thought you meant you couldn't get the data out. It was just that there is missing data, but
yeah,
you
there's
can
missing
get
data.
I see.
Exactly,
Okay.
yeah, yep.
Thank you.
You're welcome.
Your screening FOBT is about 10% population-wide?
Yes, it was 10% out of 100,000 that we're anticipating, and so
Right.
only 10% have been screened so far, but it's a continual process. We're expanding the scope of the number of barrels that are being screened, because the first one, Hai Ba Trung, there was a lower response rate, so we're thinking that by expanding it, we'll get a higher response in terms of the number of surveys collected.
So what in particular will you be able to do to enhance your yield, your return rate?
My return rate? I think that by doing the red cap in terms of the interview survey, that will help boost the numbers, because we're also doing interviews along with the self-administered. But we're also doing educational campaigns in the villages to help with recruitment efforts, and they have to contact the leader of the village so that they're able to kind of have network between the spokesperson, who will be like the trusting guide into the city, so that people will be more apt to come and participate in the survey.
And are you doing anything to target high-risk groups, even if they're only defined by age?
Not in particular that I'm aware of. I know that we do the educational training in the community, and that has been very successful in getting enthusiastic support. So once people find out about it and they hear from word of mouth about it, we had a higher percentage of colonoscopy confirmed in the beginning. And that was because people suspected that they may have had colorectal cancer or something to be concerned about, and so they were the first to come to the screening program. But later on, once more people heard about it, we got 6.3%.
So do you have capacity to do all the colonoscopies you'll need to if you,
Well, that's why it's a slow process. So I would say that's another limitation in that the staffing, you could see there's only Dr. Twee and 3 lab staff who are processing all of the FOBTs.